All right, good afternoon, everyone. I want to go ahead and get started. Welcome to the 2023 NNLM Virtual Symposium on Health Misinformation. We're glad you were able to join us today. I'm Tiffany Chavis, the Health Literacy Librarian for Region 1 of the NNLM out of the University of Maryland, Baltimore. We just have a few technical items to cover. I'm sure if you already attended some earlier sessions, you heard this. All attendees have been muted, but we do welcome your questions and comments in the Zoom chat at any time. VFairs is providing technical assistance for us today. We also have NNLM staff that will be keeping an eye on the chat with me. Please be sure to select everyone from the drop-down menu when posting your comments in the chat. This is just so we can all see what's in the chat. Submit your questions for the speakers using the Q&A function. This is to help us be able to find those questions so they don't get lost in the chat. We also have live closed captioners for this event. So you can access the closed captions by clicking on the icon with the 3 dots and then selecting closed caption. If you would like to share on social media, we encourage you to do so by using the hashtag for the event, which is HealthMisinfoNNLM. Before we get started, I would like to share a little bit about who we are. The National Institutes of Health is the nation's leading medical research agency. Many of you might be more familiar with the National Center for Allergies and Infectious Diseases, which is one of the many institutes and centers at NIH. The NLM, or the National Library of Medicine, is one of the 27 institutes and offices of the National Institutes of Health. It's the world's largest biomedical library and produces online resources like PubMed and Medline Plus. The NNLM, or the Network of the National Library of Medicine, is the outreach program of the NLM. We work to ensure health professionals and the public have equal access to health information. The NNLM is made up of 7 regional medical libraries, 3 national offices, and 4 national centers, all providing training, funding, and engagement opportunities to over 9,000 NNLM member organizations. It's my pleasure to introduce today's speakers. We have Jason K. Alston, who is an assistant teaching professor from the University of Missouri, and Nicole A. Cooke, who is Nicole A. Cooke, who is from the Augusta Baker Endowment. She's the chair there from the University of South Carolina. So welcome both to you, Jason and Nicole, and thank you for coming. I'm going to now turn it over to the speakers to share their screens and get this presentation moving.
All right, excellent. Give me one moment here to share my screen. And okay, I think we are already in some sort of technical difficulty here. Let's see here. Let's see. All right, does everybody see? Okay, I do think our presentation is here now. So, introducing critical cultural literacy, a potential weapon in the fight against online health misinformation. And this will be delivered by, again, myself and Dr. Cooke. And I think Dr. Cooke is handling this here. So I'm going to turn this back over to her, and I will be back with you in a moment.
Yes. So again, my name is Nicole Cooke. I'm at the University of South Carolina School of Information Science. And I just want to quickly thank Jason and Bobby and the team for the invitation today. So what we're presenting today is based on a chapter that we recently wrote discussing misinformation, disinformation specific to health, and also introducing the critical cultural literacy model as a potential weapon in fighting health misdis. So just very quickly, we want to give you a sense of what we're going to cover today. So we're going to talk about the prevalence of online health myths and dis. I'm sure you're all very aware of that. We're going to then talk about how are BIPOC accessing online health information. And by BIPOC, we're talking about Black, Indigenous, and other people of color. So essentially underrepresented groups. How are they accessing or not accessing health information? We're going to talk a little bit about BIPOC encounters with online health myths, dis. Could BIPOC be targeted with online health myths, dis? And then I'll introduce to you the critical cultural literacy model that we are proposing as a potential tool to combat online health myths, dis. Critical cultural literacy against online health myths, dis, and really what can we as librarians and other information professionals do in this ongoing fight that we have against myths, dis in health information. All right, so just so we're all on the same page, I want to go through a couple of definitions, and these are definitions that we're using in the chapter. And misinformation, disinformation, we're also talking about malinformation. And these were posited by Dr. Claire Wardle, who ran a think tank called firstdraft.org. So First Draft no longer exists, but Dr. Wardle has another think tank. If you care to look her up, she's one of the leading voices in misinformation and disinformation. So we're really borrowing from First Draft in our work. So misinformation, as you know, is information that's just really false, right? It doesn't have to have any good or bad intentions, but it is false information. It can be vague and or misleading. So it could be something as simple as a typo, or something, much more serious and much more malicious and deceitful. And that's where we get into disinformation. So this is information that is also false, but is deliberately false. So someone is creating information that is false with intent to mislead or deceive. So that is the difference, the main difference between misinformation and disinformation is intent. In our chapter, and as we go through the presentation, we will be talking about myths, dis, and that's a common shortcut or umbrella term for both misinformation and disinformation. And then finally, we have malinformation. This is a more specific form of disinformation. This is false information that is shared with the distinct intention of causing harm or maintaining the racial status quo. So when we used to talk about malinformation, but maybe weren't calling it malinformation, you would hear things like revenge porn or doxing or things of that nature. So that is information that can really cause harm. It's more than just misleading or deceiving people. This is false information that could literally cost people their lives, their liberty, and their freedom. And so we'll be talking a little bit about malinformation in the presentation as well. And I'll turn it back to Jace.
Okay, so as far as the prevalence of online health misinformation and disinformation, this probably surprises nobody who has joined us today, but oh goodness, okay, there we go. All right, there are many studies that do illustrate that misinformation and disinformation regarding health is prevalent in Google returns and on free websites. And I'm going to share a few examples that we have in our chapter here. So for one thing, in 2011, a team of researchers reviewed the first 1,300 Google return website results regarding infant sleep safety, which is a very important topic as somebody who is a father of a toddler, and they found that 28%, so more than a fourth of the websites provided inaccurate information, and that is very scary, more than a fourth. And then also, no, there's probably some overlap, I do want to make that clear, but also 28% of the websites provided information that was irrelevant. So again, over a fourth of the websites provided information that was irrelevant, in addition to a fourth of the websites, or more than a fourth of the websites providing information that was inaccurate. Some other studies that we cite include a study from 2019 that extracted claims about conception from websites and social media. And that study was actually done in 2017. It was just published in 2019. But it was deemed that only 60% of the claims about conception, again, a really big and very important topic, were actually accurate. And then finally, I do also want to share a 2018 study had reviewed 243 websites for information about obstructive sleep apnea and concluded that most of the websites with information about this condition were, and by most, that's at least 50%. I mean, more than 50% were not reliable or inaccurate. So, and we cite some other studies as well, but that's just to give you a hint that yes, there is a lot of bad information out there. There are other studies that reveal that health misinformation and disinformation spreads rapidly on social media. And the reason for that, social media, we all know that social media is exciting. It's the thing. There's a lot of sensationalism with social media, and it platforms everybody. So, you know, it's something that's in probably all of our lives at this point, everybody that's here. But there are a lot of sensationalist falsehoods that are spread through social media on all sorts of topics, not just health. And that is the nature of social media. It's not about getting accurate information out there. It's about getting exciting information out there, or about getting the type of information out there that causes people to react, because that is what these social media platforms, as we know, are actually driven by. It's not driven by, oh, we're getting accurate information. That's how we feel in the library world. But on these social media platforms, we have to remember that it's not about getting accurate information. What drives things to the top of results is whether or not the information causes people to engage. Remember, when you're using social media, you are the product. You're not paying for the product, you are the product. Corrections and clarifications are often actually never seen by the information consumers, and that is another problem that is compounded by social media. So the false claims themselves can be very exciting, and when we talk about health information, it is very exciting to, and I use exciting very broadly. There are probably better words I could use, but I'll stick to exciting for now. It can be very exciting to see, oh, there's a cure for something, or, oh, you know, Dr. Sebi said this, Dr. Sebi said you can cure AIDS with a herb. You know, it's very exciting to hear something like that. And it's also, I would probably not use the word exciting, but maybe I'll use the term worrying. It's also very worrying to hear about new health conditions via social media. So, and I know that the first time I ever heard of COVID-19, it was through social media. And it was very worrying, and that information spread very, very rapidly. But the corrections and the clarifications, those just aren't quite as exciting or as worrying. And so when you're dealing with these types of social media algorithms, those aren't getting spread as quickly because people aren't engaging those corrections and clarifications the same way. And so they're not being spread nearly as much. So there's a lot of just information out there, and people are repeating this stuff, spreading this stuff, resharing this stuff, and thinking they are correct, because the corrections and clarifications are what I would call an unknown unknown. The people actually do not know that these clarifications and corrections are out there because they have not encountered them. And that's another thing that we've got to keep in mind about social media. We often think, how can you think this when you have this information available to you? And we have to realize that there are people who, even though in our world, we might be seeing, in our social media world, our social media bubble, we might be seeing this information a lot. We might be seeing it constantly. We still have to remember that other people's algorithms and social media feeds are showing them dramatically different things. And so they are not going to be exposed to the same information. And so they are not creating a similar worldview because they are exposed to a lot of different worldview creating information. And again, we have to think about what the motivations are. So when we're looking at these when we're looking at like for-profit websites and everything, the goal is to generate money a lot of times. And that's true with social media too, but in a different way. But with the websites, a lot of times what we've got are people who are putting this information out there with the goal of getting hits and getting web page views. And when they get those sorts of things, then that generates profit. They can use that money to convince advertisers to advertise on their websites. Social media is also driven by profit, but really that's sort of at the top, like the people who run and own the social media or who have stakes and shares in the social media platforms. They are the ones who are motivated by the profit in that case. For people, presumably like you and I, who are not actually owning those social media platforms, but are instead using them, a lot of times people have the goal of getting the likes and the popularity and that sort of thing to be able to call themselves influencers, for instance, on social media. You get a little bit of a dopamine rush when you get a like or a love or something like that on social media. And so the psychology of that is that people are not necessarily they may think in their heads that they have the best intentions, but when it plays out in actual practice, what people are actually doing is they are trying to court likes. If their posts get ignored, they may change up what they're actually posting about because it's about engagement. The engagement is what is exciting people and what people are feeding off of with social media. And so again, and then a lot of times also, we should also mention that people do often have agendas. So somebody may have an agenda that is not necessarily to spread correct information, but they may have an agenda to spread information that supports a claim a political claim or a health claim that they've got going on. And so again, what gets put on the back burner is whether or not we're vetting to see, or whether or not the people who are sharing are vetting to see whether or not that information is accurate. BIPOC encounters with online health misinformation and disinformation. So BIPOC may be more susceptible to online health misinformation and disinformation. And it is not due to, and when I say that, it's not due to lower intelligence. Let's make that very, very clear. But there are some other things that can be going on. For one thing, social media outlets, which are a lot of times white owned, just to put it frankly. That's not always the case. Certainly that's not the case with TikTok and some others, but a lot of social media outlets are white owned, and these social media outlets may take misinformation and disinformation affecting BIPOC less seriously. This is quite a common phenomenon in all walks of life. People tend to take things more seriously if they affect the people that they relate to or that they care about. There is nuance lacking when examining diasporas. And what I mean by that, and this is also very common, is so me as an African-American, I am part of the African diaspora, but that does not necessarily mean that that health information or health research that's done on African populations or Afro-Caribbean populations would necessarily translate to being accurate if those conclusions were applied to or generalized to African American populations. Just because we share a diaspora, that does not mean that our cultures are identical. And there are some nuanced differences between, for instance, African American culture and Afro-Jamaican culture and those sorts of things. There are differences that we celebrate. Just because there are differences doesn't mean that they're bad things. But again, when we have these differences in our cultures and our ways of life and in our diets and all these sorts of things, we can't just have overarching things that say, oh, well, Black populations, this, and that, if the subjects were Africans or Afro-Caribbeans or that sort of thing. Those nuances within diasporas need to be noted. Low income, older Black adults do show a particular susceptibility to online health misinformation and disinformation, and that is attributed in this study here it is attributed to lower levels of digital access. And when they don't have as much familiarity with searching online and things of that nature, then that can become an issue as far as knowing when to vet things or how to vet things, and knowing that, okay, this isn't true, or this is something I should look and see if another website verifies. If you don't have that online digital access, you're not necessarily programmed or trained to react that way. And this is something that I found very important and was glad that this was noted. Black women may have lower bandwidth due to everyday challenges. I'm just, again, as a Black man, I'm going to say Black women are catching it from everywhere. They are catching it from society. They're catching it from men within their own race. They're catching it from women of other cultures. And so the challenges that Black women face are just substantial. And so because of that, you know, at the end of the day, when you are just taking so much from everybody, so much abuse, so much damage from everybody, it can lower the bandwidth you have to actually do the types of rigorous online research that proper health, online health researching may require. Okay, continuing. The WhatsApp app has very high Latin and Asian usage, or Asian American usage. Actually, I should say Asian usage, because these are actually used internationally. So a lot of people who are Hispanic or Asian, they do use WhatsApp to communicate with friends and family who are in other nations. And this misinformation and disinformation on WhatsApp particularly, now I'm not that familiar with WhatsApp, so I don't know exactly why, but this misinformation and disinformation is apparently harder to monitor on that particular app. Now, this is one of the causes, but this is not the absolute cause. But language diversity does make tracking misinformation and disinformation harder. So there are a lot of people, of course, in the United States. English is it's not the official language, but I would say it's the language that's most heavily spoken. It's the language that we're speaking right now in this presentation. And once you actually have things, misinformation and disinformation that's going out there in the Spanish language or any number of languages, or any language that people are speaking, it gets harder to track, because a lot of the people who may be trying to track this misinformation and disinformation, they may be people who only speak and write English, or who are not fluent in other languages. And so, yes, we do have we're an Anglo-centric nation. And so we also are more aware of misinformation when it's in English than when it's in other languages. Merited, I make sure that it is clear that this is merited, but due to the past, Black and Indigenous people within the United States have very, very long and merited distrust of the American medical establishment. And so that does drive people to alternative sources. We don't have the time to talk about it today, but if you were to review our chapter, again, Dr. Sebi, who I mentioned a few minutes ago, he's somebody who is actually disturbingly popular. I wouldn't say he is dominating in any sense. And by the way, Dr. Sebi is deceased, but a lot of the disinformation that he put out there is still making its rounds. And yes, so those alternative sources, the reason people go to those is because there are a lot of Black people who know about things that happened to Black people in the past that the American medical establishment just kind of co-signed or was involved in, and that sort of thing. And Indigenous people have faced the same. And then also it does bear noting that a lot of times white doctors or white health professionals, they can't relate to or actually perceive that Black or Indigenous patients are in pain or really are going through something. They tend to minimize the struggles that people who do not look like them are going through, and not understand the significance of what people are encountering. So could BIPOC be targeted with online health misinformation and disinformation? I could not I did a very thorough search of the research and literature out there. And to be quite honest with you, I don't see a lot of evidence that BIPOC are currently being targeted in online health misinformation and disinformation campaigns. But there is, and we don't want this to turn political really, so we're not going to talk about the politics too much, but we do sort of subtly make the argument within our chapter that because BIPOC are targeted with online political disinformation campaigns, and they are very blatant, that this could also end up being the case with online health misinformation and disinformation as well, that it could happen, even if it's not happening or not happening in abundance now, because you never really know if somebody is out there trying to commit genocide. This might be the way to go, is to target our people or target any population with online health disinformation. Now, I will say that there is an entanglement of health and politics. So even though we want to keep this off of we don't want to get too political with this, but there's no denying that there are certain issues that are both health issues and political issues, such as health insurance and health coverage, and whether or not we should have single payer. Also, abortion, that is a big one. Abortion is probably one of the biggest political issues out there, but is also necessarily a health issue as well. Now, BIPOC, I just mentioned that, yes, BIPOC are already targeted with online online misinformation and disinformation regarding abortion, and there were political components at play there. But again, I don't want to get too much into that for the sake of keeping this not too political right now. But there is also a precedent. This is not online health information or disinformation. It's just health misinformation and disinformation in general. But there is a precedent for targeting Indigenous peoples with health misinformation and disinformation. These are the firewater myths that have endured, and a lot of you all are probably familiar with these suggestions that Indigenous people have some sort of genetic susceptibility to being to alcoholism. These are complete myths. There's no scientific grounding in this type of information, but that information is, or I should say, disinformation is prevalent. And so if the precedent is there that a BIPOC population has indeed been targeted with health misinformation or disinformation in the past, I would say that once the precedent is established, we can't write off that it could potentially happen again. Right, and I'm going to turn it back over to Dr. Cooke.
All right, thank you. So now we want to talk a little bit about excuse me for the noise. We're going to talk a little bit about the critical cultural literacy model, and the citation to this article will be at the end of our presentation, and it will lead you directly to an article that I wrote during the COVID pandemic, and it's open access if you care to read a bit more. But essentially, I was talking about Dis, talking specifically about malinformation. So a lot of the examples that Jason has gone through with us really could be considered malinformation, right? So if we're thinking perhaps not as much about the intent, right, it's still disinformation, but the results, if people are dying or become very, very ill from COVID or any other, health problem because of a lack of information, that really could be considered malinformation. And so when we're talking about critical cultural literacy, it was really an effort to bring together a lot of the literacies that we all know about as information professionals, and really emphasize this idea that nothing happens in isolation. And when we are talking specifically about mis, dis, and malinformation, we need context. We need to know what's happening around the actual piece of information, not only so we can get a better sense of what's happening, but also we can get a better sense of how we might debunk this mis, dis, or malinformation. Jace, could I have the next slide, please? And so in this model, talking about a couple of different types of literacy. First is information and media literacy. And we as information professionals are specifically familiar with that. And so how do we teach people how to use information in a way that is replicable on their end and helps them make good democratic, positive decisions, etc. And media literacy as its own genre, but also as an extension of information literacy. And we're seeing a lot of this now. How can people go through images and other types of media as well? Just a quick example, even last week, there was a picture of the Pope in a puffy jacket, right? And there are still people who thought that that picture was true, right? And we need to really up the ante on our instruction and our strategies, so people will know how to determine what they're seeing is true or false. Let me go back to the top. I didn't mean to go out of order. We have racial literacy and cultural literacy. So I'll talk about them together. And this is part of the context, and this is really what our chapter is about. Jace mentioned that people have different feeds. I mentioned in the chat that people have different circles of whom, folks that they trust, right? And so this all looks different, and it can be definitely affected by a person's race, ethnicity, and their culture, right? Who they are taught or socialized to trust. So for example, in the African-American community, the church and religion and the pastor are folks that you go to for counsel, right? So that may very much impact what information people have access to. And certainly in other cultures, other religions, et cetera, that might be very different, right? So when we're talking about mis, dis, and mal, we can't look at it from just one lens or look at it just from the lens that we're used to. We have to look at the bigger picture of who's interacting with the information and what that might look like. We need to talk about emotional literacy. And this is actually a lot of where my work resides. I put this also in the chat. People are looking for information that makes them feel good, right? That confirms what they already know. So we talk about that as confirmation bias, but it is a form of emotional literacy. Now, if I really like Jason and, we get along and all of these things, and he doesn't present information that challenges me or makes me angry, I'm more inclined to believe what he says, right? So similarly, if I don't like Jason for whatever reason, he could be telling me the absolute truth, and I won't believe him because he makes me angry or he makes me uncomfortable. So we have to think about how people are emotionally reacting to the information they encounter. Historical literacy, I think, is really important, and a really obvious example that came up during the pandemic that's related to our chapter is, the susceptibility of, or I should say, the distrust of African-American communities towards the medical establishment. So there was a lot of talk about the Tuskegee experiments and other types of abuse, essentially, that was targeted towards communities of color by the medical establishment. And so that was proposed as one of the many reasons that people might be hesitant to receive the vaccine, right? So that's a little historical literacy. But I will say, with any of these literacies, no group is a monolith, right? So there were some folks that didn't care about the Tuskegee experiments. They said it was in the past. And there are other people in 2022 that very much said, I will not get that vaccine because of that study. Okay. Political literacy, like Jason said, we're not going to get into that, but I do want to acknowledge this idea that a lot of terms are being politicized, and that really does impact how we have conversations and if we can have conversations. So we do need to acknowledge, the larger landscape and how information is being weaponized against people and, perhaps privileged to other people. And the last one here, and by no means is this a complete list, this is just what comprises this particular model with an emphasis on race and culture, is design literacy. And by design literacy, we're talking mainly about the design of a website, the interface. How easy is it to access information? Right now, as academics, as information professionals who have access to different databases that are behind a paywall that we pay to subscribe to. The average person, on the street may not have access to these things, right? So there are different layers of design and access issues and barriers that we also need to consider. So if we think, they really should have known better, they might not. Because as Jason was talking earlier, access is an issue and design plays a role in the access of information. All right, so I'm going to turn it back to Jace to talk about what we as information professionals can do.
Okay, yes. And so just very quickly, I would say that I wrote this up into K-12 academic and public librarians and what can be done. I'm a firm believer, and this is part of my research agenda, so I'm hoping to get there at some point and actually put it to research. But I'm a firm believer that actually when it comes to emotional literacy in particular, we do need to start getting people in elementary school, students in elementary school, accustomed to not vetting information based on emotion. And that is something that, because I think that even by the time students are in high school, it may be too late to try to break that. And I do remember, unfortunately, this experience is not shared by a lot of my peers and a lot of people that I speak to, but I remember actually being in third grade and our teacher giving us magazines. We had print magazines back then. I'm sure we do now too, but everything's online now. But our teacher gave us print magazines and asked us to just look at advertisements in particular and see if we felt that anything was misleading. And then she taught us about what was misleading. And so there was, especially when it came to toys and that sort of thing, there was kind of an inclination within third graders to want to believe something based on, okay, this is what I want to believe, so it has to be true. And you can sort of break down those emotional sort of leanings really at the elementary school level. I think you have to start conditioning again at the elementary school level for separating vetting information from just determining, okay, I like this and therefore it has to be true, or therefore I want it to be true. And so I'm going to try to confirmation bias. I'm going to look for things that make what I want to be true. So that's but you don't, I will say that both within K-12 and academic, you don't actually need to share the whole module. You don't need to share, again, if I went back to the graphic, I don't know that your college freshman or your third grader really knows what to do with our image here and making sense of that. However, when it comes to academic librarians, one thing that we can do is we can make modules that sort of test the or assess the competency of our students and whether or not they are able to approach information they encounter with a critical lens of, hey, this may be historically inaccurate, or it may be there may be some cultural things that aren't considered in the information that's presented here. And so even if they are not, even if your college students aren't really interested in the minutia of what critical cultural literacy actually is, you can still develop modules that test the different components within critical cultural literacy and make sure that students are becoming competent in vetting to make sure that everything is historically sound, culturally sound, politically sound, and so forth and so on. And then when it comes to public librarians, that one I kind of struggled with, even though I do also have some public librarian experience, but I will say that we didn't necessarily have captive audiences with our patrons in the public library when I worked there. But when you're working with patrons one-on-one, which was a lot of what I did. I didn't do a lot of instruction in that role, but when working with patrons one-on-one, when we knew that they were looking at health information online, which happened a lot at my job, one thing that I would do would be I would try to, first of all, navigate them to our paid databases or our proprietary databases if possible, but then also just making sure that if you're sort of looking over the shoulder or helping somebody with their search or something like that, you can just sort of be the person who is looking in these at these lenses and then telling your patron that these are some things they can consider. So if you see something that's historically accurate, then you can tell your patron, if you know it's historically accurate, you can say something to your patron to gently let them know that what they've accessed may be historically inaccurate, or it may not be applicable to their culture or those sorts of things. So you will probably have to be the one looking at the various components of critical cultural literacy and just applying them and helping your patron apply them. So that it would be the recommendation that I would have for public librarians. And then we've got references and any questions.
I don't see any questions in the Q&A, and I didn't spot any in the chat either.
I just want to take a minute and thank Dr. Cooke, and I think I saw Dr. Alston in the introduction slide. So apologies for that earlier for this presentation. It was wonderful. So if anybody does have any questions, feel free to put them in the chat or use the Q&A function. We've got about 15 minutes for questions, but I'm really wonderful. I thought this was wonderful, so thank you.
I'll second that. And I also said the same thing about the introductions as well.
Well, I will say that this, I'm sometimes maybe too transparent, but I will say that this was Dr. Cooke was the one who envisioned this, and I'm just thankful that she invited me onto this project, because that's how this went down actually. But this is it was actually one of the most fun pieces I ever I had so much fun writing this and everything, and so I was very thankful for that opportunity. And so I'm also very thankful to you all for allowing us to present this here as well.
Likewise, let me piggyback on what on Jason's thanks and to Leah's question. Jason, if you could go back to the reference slides, there is a link to the chapter, and it's called Sweet Little Lies, and it came from Project Information Literacy. So if you type in Cooke and Sweet Little Lies, it should pop right up. And that will walk you a little bit more through, yes, Tell Me Sweet Little Lies, Racism as a Form of Persistent Malinformation. And that walks you a little bit more deeply through the creation of the model and talks a little bit more about each literacy. So I saw that Leah had that question, and yes, Janet, 100%, right? I'm with you too. All chocolate and all wine is good for us, right? And so again, part of how we emotionally respond to information.
We do have one question now from Samuel. It says, can you speak to the two-way nature of trust and information? We speak a lot about trust in health providers, but what about trust in the abilities, potentials of marginalized communities? Then it goes on to say an ability of marginalized communities to inform research, inform healthcare, etc.
So is it the trust of the communities towards the information, or the trust that we have that they can find it? Is that the dichotomy we're talking about?
Ability of marginalized communities to inform research and inform healthcare.
Okay, so I think the informing might be a little different than the access. So just off the top of my head, because I think I would need to ponder this a little bit. I'm not sure trust is the right word in terms of, whether we think marginalized populations can access the information. I think part of that is, again, about access, but certainly I think, we can trust them to find the information once, they are quote unquote taught how to do it. And we also need to trust that they know their bodies, their own conditions, their own information needs. So I think in that perspective, we definitely need to trust the communities that we work with, that they know, they're the experts in their own information needs. In terms of informing the research, like Jace mentioned earlier, there's still so much research that needs to be done. And I think that BIPOC communities can absolutely take us to the next level in understanding how our communities are interacting with mis, dis, and malinformation, particularly as it relates to health. Jace, any thoughts on that?
No, that was both of the questions that we've gotten in the Q&A have been great. I did type out an answer to the second one, but I didn't. I wanted to make sure it didn't get ignored because it went to a different tab once I typed that out. So I apologize for that. But yeah, I didn't have anything really to add to that. I think I'm in full agreement with you.
All right. Is there any other last minute questions before? Oh, wait a second.
Yeah, I see there's one that just came up in the chat.
Yes. Can you share any strategies that you have found to assist educating BIPOC communities that some information is inaccurate?
I can start with this one, and you'll see this example in the Tell Me Sweet Little Lies article. In my experience as an instruction librarian and now as a classroom teacher in a graduate LIS program, I tend to look for two things, or I should say utilize, not look for. I think it's important for us as educators to be vulnerable and also to be willing and able to share some of our experiences. So for example, really early on in the chat, I typed out that at the beginning of the pandemic, there was some strange report, but it was on mainstream news that African Americans could not contract COVID. Now, I study this for a living, and I was truly excited for about 2 minutes when I thought, ooh, I'm good, right? And then I said to myself, you fool, you know better, right? So, this kind of sharing experiences and letting our communities know that we too are susceptible to mis, dis, and malinformation. I think I hope it contributes to the trust. Also, I think, using really relevant examples is helpful, because the relevant examples are going to be more important to the community that you're working with, hence one of the reasons that the model is particularly important, because the more we know about a particular community, the more that we can try and get relevant examples and relate to them with things that are important to them. Jace, any strategies?
No, I don't have any. I think sometimes it just comes from, with me, it just comes from trust. I would say, again, on a personal level, I'm from a predominantly Black rural area. And so there is that mixture of both being, there's both Black culture and Southern culture at play there, and rural Southern culture at play there. And these things kind of play into a situation where outsiders just oftentimes are not trusted. So a lot of times it just takes, this is why I'm a firm believer in people after they receive college education. Oh, thank you for putting that link in the chat. I think that it's a lot of times it does come down to just you've got to maintain ties to your home communities. If that's the type of community you come from, you can't forget where you come from, because a lot of times once you have that benefit of a college education, I can still go back to my hometown and be trusted in ways that quote unquote outsiders cannot be. You can have the medical the medical degree. You could have been like a brain surgeon for 40 years. But if you say something that if you say something that raises an eyebrow, it could be totally true. But if they're perceiving you as an outsider, then they still may be resistant to you, especially if you give some sort of emotional, especially if they get some sort of negative emotional reaction from you, and it could be entirely not your fault that they do. And yet I could say the exact same thing, and I had not been to medical school a day in my life, and I would be trusted. So really it does come from, unfortunately, it does come from being able to be trusted. And a lot of times being trusted means being from the community and knowing the struggle, because in the same way, I will say that there is a two-way nature in that, in the same way that a lot of times white doctors aren't perceiving the real pain or the real suffering of patients of color. There are also those who are in these communities who cannot they can't I want to word this in a way that's not controversial, but if they see somebody who's not quote unquote real or doesn't have the cred, as we say, then that person still might be dismissed because they're seeing you as somebody who hasn't earned your stripes. That might be a better way to put it. And, if they see me and they know that I'm from the same community that they're from, then they may see me as quote unquote real or authentic, and what I say is real and authentic. So that's one of those things that, yes, it is. When someone was asking about the two-way nature, that's definitely a two-way thing, that trust and understanding of what is real and what isn't.
Mm-hmm.
And I do want to say thank you for the applause that we are getting and that sort of thing. So yeah, we will be here for, I guess, another few minutes. But if there are any other questions, by all means, please ask at this time. And also, I'm willing to. I can be Googled, and if you find my email online, you can feel free to email me as well. I don't mind. I may not have an answer to your question. I'm not going to make an answer up, but if you email me and want to ask me something or give me feedback, you can do so.
Okay, there's no more questions. I don't see any popping up. All right, well, I am going to close up. We did have a lot of thank yous. I see some clapping. I see excellent presentation. I am going to agree with that comment. But I already knew that coming in, so I knew it was going to be a good one. Okay, so I am going to share my screen now. So thank you all for attending. I want to say thank you to Dr. Alston and Dr. Cooke, and to all of you for joining us for day one of the Health Information Symposium, Misinformation Symposium, rather. This is the last session of the day. We look forward to seeing you all tomorrow for a keynote. Jevin West, co-author of Calling Bullshit, Data Reasoning in a Digital World. Lastly, before we wrap up, I want to encourage you to join the network. Membership is organizational, not individual, but offers benefits such as funding opportunities and print resources. And then lastly here, for real this time, if you would like to continue exploring misinformation, please join NNLM at the upcoming sessions that we'll be having on health misinformation. It's a webinar series. The series features presentations from expert guest presenters, guest speakers, and will enable librarians, public health professionals, health educators, and healthcare providers to explore various aspects of health misinformation, disinformation, and malinformation, and also learn practical and evidence-based solutions for how to identify it and how to curb its spread. These presentations will be scheduled intermittently throughout the year, and you can also learn about upcoming sessions by checking out the NNLM training calendar on our website. So again, thank you, and we look forward to seeing you all tomorrow.